All right. Hello, everyone. Thank you all for joining today, and welcome to our ATS Thoracic Oncology Assembly webinar, which will feature four of our ATS 2025 International Conference Abstract Award winners, Tonia Bargmann, Julia Katcher, Kaele Leonard, and Andie O'Loughlin. I'm Roger Kim, chair of the ATS Thoracic Oncology Early Career Professionals Working Group and assistant professor of medicine at the University of Pennsylvania. And I'm joined by Tejaswi Nadig, assistant professor of medicine at the Medical University of South Carolina. And today we'll be co-moderating the session. Before we get started, I just wanted to remind everyone that this is a live event, but it will be recorded and uploaded to our Thoracic Oncology Assembly ATS website and our YouTube page shortly thereafter. And if you register, then you'll also receive an email with a link to watch this recording if you're unable to stay for the entire session. If you do have any questions throughout the webinar, please place them in the chat, and Tejas and I will do our best to try to address as many as we can, time permitting throughout the session. As a reminder, the views expressed during this webinar are those of the speakers and ours alone, and not necessarily endorsed by the ATS. With that being said, we have four excellent presentations on the docket today, and we'll kick things off with Tonia Bargmann. She is a PhD candidate at the Fraunhofer Institute for Toxicology and Experimental Medicine in Hanover, Germany. And the title of her talk is Ex vivo stimulation of patient-derived tumor lung slices with anti-PD-1 and anti-CD39 induces CD8 positive T cell and macrophage responses. And you can go ahead and start sharing your screen, Tonia, and looking forward to your presentation.
So thanks everyone for joining this webinar today. I'm really excited to be presenting some of the work that I generated during my PhD thesis. I hope you learned something new, see something interesting. I'm excited for your questions in the end. So without further ado, my title was already introduced, so I'll jump right in. So as we know, the tumor microenvironment is incredibly heterogeneous, not only across different tumor entities, but also really between different patients. So that makes treatment quite difficult because there's no one-size-fits-all kind of treatment. However, in the last years, one type of immunotherapy, checkpoint immunotherapy, was really a great breakthrough for cancer therapy. One thing that really shows this is that Keytruda, an anti-PD-1 antibody, was the most sold drug in 2024, actually. So the idea here is that anti-PD-1 blocks the binding of an inhibitory receptor on exhausted CD8 T cells, which normally would bind its ligand PD-L1, blocking their function. But with this antibody, you can reinvigorate exhausted CD8 T cells to continue their job in killing cancer cells in the tumor. So this sounds like a really great mechanism in that it really exploits the immune system to eliminate cancer cells. However, only around 20% of patients really mount a durable response to this therapy, either due to primary or secondary resistances, which means as scientists, we still have some work cut out for us. And there's different things ongoing or different research ongoing to look at other checkpoint inhibitors in other antibodies. But what's especially important is to be able to modulate the full tumor microenvironment. And one marker that's come up in recent years is CD39. So CD39 is not only expressed on exhausted T cells here, but also on many different immune cells, macrophages, regulatory T cells, and especially cancer cells. So different tumor entities or different cancer cells will upregulate this marker CD39 and exploit its function. So its function in the tumor microenvironment is actually to convert extracellular ATP, which is a very pro-inflammatory marker, into adenosine, which is further in this cascade into ADP, which further in the cascade is then converted to adenosine, which is a very anti-inflammatory molecule. So this is exploited by these cancer cells in the tumor, creating an anti-inflammatory microenvironment and also inducing immune escape so that these cancer cells can survive. So an idea here was to block this conversion of extracellular ATP to adenosine, thereby increasing the levels of extracellular ATP and hopefully turning this anti-inflammatory microenvironment into a pro-inflammatory one. So exactly this mechanism is being exploited in different clinical trials, and different anti-CD39 antibodies are being tested, both for metastasis in solid tumors. How exactly this works in non-small cell lung cancer, for example, is not completely understood, especially in the context of patient material and in these heterogeneous microenvironments. So the goal of my thesis was to unravel patient-specific immune responses in the native tumor microenvironment. And in order to do this, ideally, you would need patient tissue. So this is exactly what we did. So we generated precision cut lung or tumor lung slices. This is a method, the lung slices is a method that we've used in our lab for over 20 years. So I'll just go through explaining how this works. And the whole system is really to be able to maintain the native lung and tumor microenvironment. So you maintain the immune cells, you maintain the structural integrity of what the lung looks like, which is what's so great about this method. So as you all know, if the lung is outside of the body, there's no air, it's deflated, which means it's quite difficult to work with. So we developed this method to fill the lung with agarose, which you see here on the left. You see the inflated structure basically, and this allows us to target or look at in detail which regions of interest we have. So here we have the non-tumor region, which is at least 10 centimeters away from the tumor center, which is basically our positive control in a sense. Sorry, our negative control, which shouldn't be reacting to the immunotherapy. And then we have the tumor tissue. Here we specifically look at the tumor border. We found that the tumor border is really our region of interest, not only because it's most viable, because also tumor center can be very necrotic, but also this is where the highest infiltration of immune cells occurs, and really where we want to look at. So these regions are defined on a macroscopic level by a pathologist, so we work very closely with our clinics here. And then we can cut these slices, or these cores, which are 8 millimeters in diameter, using a chrome-leak slicer into 300 micrometer thick slices. And these slices, like I said, are viable. They can be cultivated. And after cultivation, there's a plethora of different readouts that you can look at, which include H&E stains, and I've just brought 2 of them here with me. You have the non-tumor tissue, which largely looks like a very normal lung structure. You have an airway here. And then the tumor border tissue, where you really see the restructured tissue here at the bottom. If you zoom in, you'd see tumor cells, immune cells, etc. And then the other half, which from far away almost looks like normal lung tissue. So these we can then cultivate. We've used anti-PD-1 sort of as a positive control, and also to look at some specific T cell subsets that have been reported to be very important in this treatment. And then to look at a more preclinically relevant antibody, an anti-CD39 antibody, as I said, is currently in clinical trials. So just to confirm that our targets are really expressed in our tumor tissue, we used flow cytometry and found that on CD8 T cells in the tumor border, they express a lot more PD-1 than in the non-tumor tissue. And the same is for CD39. When we looked at CD39 expression on EpCAM positive cells, which represent our tumor cells, again, we see that there's more CD39 expression on our tumor cells compared to the non-tumor tissue. So without further ado, let's go into some of the data. So nivolumab is an anti-PD-1 antibody, and we found it does induce secretion of pro-inflammatory factors by the tumor. So we basically looked at the cytokine secretion by the tissue itself. So this is a cultivated tissue and what we find in the supernatant. And here we see interferon gamma, a pro-inflammatory cytokine important for tumor cell clearance, is specifically upregulated or highly secreted by the tumor border after treatment with nivolumab, as you see here. And then the same thing happens for IL-2, which is an important cytokine for T cell homeostasis, for perforin, which is important for tumor cell killing, and also for IL-1 beta, which suggests myeloid involvement. What happens with TGF-beta, as you see here, it's a very anti-inflammatory cytokine. In some patients, there's a decreased secretion of decreased amount of TGF-beta in the supernatant, suggesting that some of these pro-inflammatory pathways may also help in reducing the anti-inflammatory microenvironment. that's here. What's also really cool to see that all of these responses are or donor specific. In this case, each shape represents one donor. And you really see, for example, this donor had an increase in interferon gamma, some had no change, some had little change. And the idea is here that you really see this in very early time points. So this is 30 hours after cultivation already. So to take a closer look at which T cells are involved in this response, in recent years, it's become more known that a specific CD8 T cell subset, which is residence, so CD103 expression indicates their tissue residency, and CD39 also indicates their exhaustion or even antigen recognition state. And here we see that this population accumulates in the tumor border, so in the tumor tissue we see here. So the frequency of CD8 T cells that express these two markers is higher at the tumor border compared to non-tumor tissue. And this is also reflected what's seen in the literature in different tumor entities as well. But especially we see this also here in the non-small cell lung cancer samples. So this is again flow cytometry, and to take a closer look at the phenotypes of these cells, we split these into the 4 quadrants. So we see here the double positive quadrant up here, the T cells that express both CD39 and CD103, then the double negatives, which express neither, then the CD103 single positives up here, and the CD39 single positives. So we compared the intracellular interferon gamma levels of these T cells, of these subsets, and found that this double positive T cell subset expressed the most amount of intracellular interferon gamma. And a similar thing happens with Ki67, which is a proliferation marker of these T cells. And these double positive T cells express a lot more Ki67, not only in the tumor border, but specifically this subpopulation. So this really supports what's seen in the literature that these T cells are tumor specific or tumor reactive. To take a closer look at what happens when you look at them in nivolumab treatment, we indeed saw that this double positive CD8 T cell population upregulated the early activation marker. It upregulated the degranulation marker CD107A, which correlates with what we see with perforin, because CD107A marks the secretion of perforin and granzymes, for example. Then when we looked again at intracellular interferon gamma, we found that again, this double positive T cell subset increased the expression of intracellular interferon gamma, suggesting that this T cell subset substantially contributes to the interferon gamma secretion that's coming from the CD8 T cells. So this is just supporting again what's also seen in the literature, that the frequency of this T cell subset correlates with overall survival after nivolumab treatment. So then to look at our preclinically relevant antibody, just a short reminder, if you block its function, you should theoretically increase the extracellular ATP levels. And this is exactly what we saw. So when we looked into the supernatant of the tumor border and measured extracellular ATP levels, we found after treatment an increase in extracellular ATP in most donors. To then look at what happens in the full tumor microenvironment, we again looked at some cytokines. This is actually the beginning of some unpublished data. So if you're interested in a little bit more of this mechanism, keep your eyes peeled. So we looked at these cytokines and we found that IL-1 beta and IL-18 were secreted in higher levels after treatment with CD39. Both of these cytokines are associated with inflammasome activation and also the myeloid compartment. So we decided to look at the myeloid compartment, specifically macrophages, which we denoted by CD68 expression. And after treatment in the tumor border, we found an upregulation of CD86 and HLA-DR, both of which are M1-like markers, so markers that suggest pro-inflammatory macrophages important for tumor cell clearance. What we also saw, however, is that CD73 was upregulated on these macrophages. CD73 is the second part of the CD39 cascade, which converts ADP into adenosine. So this seems like there's some kind of compensatory mechanism going on here, which would be very interesting to look further into. And so in conclusion, I hope I've been able to convince you that with anti-PD-1 treatment, we were really able to show direct secretion of these pro-inflammatory cytokines by the tumor border tissue. We were able to confirm that this double positive CD8 T cell population is specifically activated by nivolumab treatment, and increases activation markers and intracellular interferon gamma levels. Furthermore, with anti-CD39 treatment, we were able to show this mechanism that macrophages are involved in this process, possibly inflammasome activation and increase of M1-like markers on macrophages. So in the end, I hope I've been able to convince you that these ex vivo slices are really a valuable model, not only to study the patient-specific responses, but also maybe unravel some new mechanisms of treatments, further treatments in the clinics. Of course, what we would really like to see is to correlate the data we have here with patient data, because what we see here in an ex vivo setting, in the best case, would be somehow reflecting what happens in the patient. Yeah, so with that, I'd like to end my talk. Thank you very much for listening. And I'm open to your questions. Oh, I'm sorry. Of course, my last slide, I forgot to thank everybody. I'd really like to thank the PCLS members. So my entire team that works with these precision cut lung slices, it's a lot of work. It's very tedious work, and it really requires a whole team of people to do this from front to back. Of course, my supervisors and the hospitals that we work with, obviously all the patients that gave their consent that we're able to work with their tissue. Without that, we wouldn't be able to do any of the work that we're doing. So we're really very thankful that we can do this work. Yeah, so thank you very much for listening.
Wow, Tonia, amazing presentation. This really is a tremendous amount of work that you just presented, and I can see how it was very well received, it sounds like, as you were sharing earlier for your thesis work. So congratulations on completing this tremendous work. Um, I just had a question. So you mentioned, that as you were introducing the target of CD39, that, even though this particular set of studies that you shared was focusing primarily on the effect of anti-CD39 on macrophage and T cell function, you did allude to that, anti-CD39 has also previously been shown to have a pretty wide-ranging potential impact on other types of cells, Th17, natural killer cells, myeloid-derived suppressor cells, extracellular vesicles, Tregs, fibroblasts, et cetera. I know that some other preclinical studies have suggested in mice that there might be increased risk of venous thrombosis among CD39 deficient mice, given the role of CD39 and platelet activation and recruitment. And obviously, this will be further evaluated, in clinical phase 1 trials, as you mentioned. But how do you foresee off-target anti-CD39 related inflammation impacting future directions of your work, if at all?
I mean, off-target CD39 is a very it's part of the homeostatic system of the immune system, right? It's just exploited by immune cells. In autoimmunity as well, CD39 is overexpressed sometimes. So it's really with every immunotherapy, you have off-target effects. You have an overactive immune system, cytokine storms. Especially if you target something that's expressed on so many cells, you could have a better function, of course, or a better outcome, but also you are blocking the natural immune suppressive systems that's happening in the body. So this is, yeah, to be expected as well. Yeah.
Great. If anyone has any additional questions, please place them in the chat. Otherwise, I have a couple more, and Tejas, feel free to jump in as well. So this is probably a very kind of simple question, but you presented, the two different groups that you're comparing between the tumor border cells and then, of course, the sort of control or the non-tumor involved cells. Just out of curiosity, I'm sure this is kind of just convention, but myself not being a basic science researcher, do you ever compare, I guess, like cores from the center part of the tumor and see if there's any kind of comparison between that as like a, I guess, super positive control, comparing that with the tumor border cells, for example? Or like, can you explain a little bit more about the back story and the rationale behind using tumor border specific cells?
Yeah, so for lack of time, I wasn't able to go into this. We actually recently brought out a paper about this where we compared all four regions. So we compared the non-tumor tissue, the tumor adjacent, which is under 3 centimeters away from the tumor center, the border, and the tumor center itself. And of course, we wanted to look at the ability to cultivate this tissue. The tumor center is okay to cultivate, but really, if you want to look at readouts and have clean flow cytometric analysis, and we're very stringent with our viability because, of course, you want to maintain all of the immune cells or all of the functionality of the tissue. And the tumor center just doesn't look as great, to be honest. We've done some experiments where we did activation with anti-CD3, CD28, just to activate all T cells. And you do see, if you look at CD39 expression, for example, it's actually higher in the tumor border versus tumor center. So you do see kind of like the closer you get to the tumor, the more CD39 expression there is, and the tumor center, this drops down a little bit. And the T cell reactivity is also very different when you compare the tumor center and the tumor border. And I know there's a lot of correlations as well, looking at tumor adjacent tissue and patient outcome. So yeah, in further studies, it would be very interesting to look at these two regions maybe. Tumor center, I'm not sure if that's so great to use for cultivation. Yeah.
Interesting. And then if anyone else has any questions, please place them in the chat. And I just have one final question, and then we'll unless anyone has others, and then we'll probably move on. But you did mention as well, going back to sort of the model you're using, the agarose filled lung tissue, which obviously never heard of. It seems like a pretty nice model that your team has developed. Can you tell us a little bit more about sort of what initial steps were taken for validation and comparison, if any, to other models that other labs have used to study these types of treatments?
To other models, I guess you maybe mean patient-derived organoids or maybe tumor fragments. There are different ways to look at this. Sorry. So initially, our lab generated these slices to look at normal lung tissue. So originally, this was to study asthma, airway constriction, and these kinds of things. So for my thesis, it was just kind of a pilot idea to look at the tumor tissue. So this is actually not something our lab looks at. But I think for our study, what's really great and what I would love to do in the future is to do more imaging analysis. I mean, flow cytometry is great to look at subsets of immune cells, but what's so nice about this model is that you really have a maintained structure. So for organoids, you dissociate the tissue, you bring everything back together. For fragments, the problem is that the fragments aren't necessarily easy to standardize. And so what we have, our pathologists actually really enjoy when we come to fill the lung because it's much easier for them to also decipher what the structure, and it's easier to really say we have the tumor border, we have the tumor center, because otherwise if you have the deflated tissue, you can't really define the regions as nicely. And we're really part of the DZL, so the German Lung Society. We really are trying to standardize this method across different labs so that you can actually compare these results. Because some people don't fill with agarose, some people have different sizes of slices, and of course that's really difficult to then compare across different labs.
Wonderful work, and that's very innovative. And you would have fooled me looking at those path slices when you you showed them. So great work. With that, I think we're going to move on. And so next up, I'm pleased to introduce Julia Katcher. She is a fourth-year medical student at Thomas Jefferson University, Sydney Kimmel Medical College, and she will be presenting her work entitled Lung Cancer Diagnoses Among Lung Cancer Screening Program Participants with Family History of Lung Cancer. And the floor is yours, Julia. Go ahead and share your slides when you're ready.
Can you let me know if you can see that, okay?
It looks fantastic.
Okay. Thank you, Dr. Kim, for the introduction. Again, my name is Julia. I'm a medical student from Thomas Jefferson in Philadelphia, which is part of Jefferson's lung cancer screening program. I'm going to be talking about how family history impacts lung cancer risk, specifically among people who we already deem to be high risk for lung cancer based on screening criteria of age and smoking history. So when we think about lung cancer screening, the guidelines from the U.S. Preventative Services Task Force are very clear. It includes people aged 50 to 80 with at least 20 pack years of smoking and people who currently smoke or who have quit within the past 15 years. And there was a study published in April of this year from Mass General that found half of diagnosed lung cancer cases between 1992 and last year would qualify for screening under the current criteria. And I think this really highlights the important roles of other factors that make up lung cancer risk that aren't captured by our current criteria, including family history, which I'll be talking about today, but also occupational and environmental exposures and chronic lung disease. And to this point, many existing lung cancer risk models include family history of lung cancer in their predictions, such as the PLCOM 2012. So, although family history is a known risk factor for lung cancer, like I said, it's not yet integrated. And we have GWAS analyses that have identified chromosomal regions associated with lung cancer risk, but we don't yet fully understand the genetic susceptibility in lung cancer. There's a retrospective analysis of international lung cancer consortium data that demonstrated having a first-degree relative with lung cancer increased the risk of lung cancer diagnosis in the individual by over 1.5 times, and this was even after adjusting for smoking status and pack years. And the TALENT study, an important prospective clinical trial that was published in 2024, found that in a screening ineligible population, so people with low smoking intensity or no smoking history, family history of lung cancer among the first degree relatives significantly increased the risk of lung cancer in the individual, as well as the rate of invasive disease with increasing age. So I think these two highlight that whether our patients have a smoking history or not, we might be able to use this information to identify people who would most benefit from lung cancer screening. We focused on family history among people who smoke, and our objective was to determine whether lung cancer diagnosis was more frequent among screening participants with a family history compared to those without a family history of lung cancer. And the way that we did this was we extracted data from the registry of our lung cancer screening program at Jefferson. All of our participants met the USPSTF screening eligibility criteria at their time of enrollment and completed lung cancer screening between January of 2018 and July of 2024. At the time of intake into our program, all of the participants complete a baseline intake form, and this is including self-reported family history where participants can record the number of relatives affected and also the degree of relatedness of these relatives. We then identified the lung cancer diagnoses occurring before October 2024. Those identified by the Jefferson screening program, but also cases that were discovered outside of screening. So that includes between annual screens and also in those lost to follow-up. We confirmed every diagnosis using EHR data and ICD-10 codes, and then we used several types of analysis to examine the data. All of our tests were double-sided with a p-value of less than 0.05. Here is the presentation of the baseline characteristics of our cohort, who are a diverse mix of patients from multiple sites across the Philadelphia region. Just over a quarter of our cohort reported a family history of lung cancer, and we found several statistically significant differences between those with and without a family history of lung cancer. So as you can see here, the group with a family history of lung cancer was comprised of more females, fewer Black individuals, individuals with a greater smoking intensity on average. They were more likely to have COPD, and unsurprisingly, they also had a higher PLCOM 2012 lung cancer risk score than those without a family history. Our primary finding was that people with a family history of lung cancer, even among an already high-risk group, these participants who were already eligible for screening were more likely to be diagnosed with lung cancer following screening. But when we classified lung cancers as screening detected versus non-screening detected, like I mentioned on the previous slide, we didn't find a difference between the two groups. And we did take a closer look at the cohort reporting a positive family history, where we found that the diagnoses of lung cancer occurred more frequently in people with a first-degree relative versus those with second or third-degree relatives. This data isn't shown here, but it demonstrated a trend toward significance. And then we did not find an association between the number of family members affected by lung cancer and the individual participant's lung cancer diagnosis. We also carried out a multivariate logistic regression analysis. Family history of lung cancer was significantly associated with lung cancer diagnosis in the univariate, and then even after controlling for age, gender, race, smoking intensity, and personal history of cancer, it remained significant, with the family history group having a 1.7 times higher odds of lung cancer. And then, although with weaker associations, smoking intensity and age also remained significantly associated with the lung cancer diagnosis after adjusting for these covariates. We also took a look at histology and stage among lung cancer cases in our cohort. We found that small cell lung cancer was twice as frequent among patients without a family history of lung cancer. And then among patients with a family history, there was greater frequency of individuals with stage 4 disease at the time of diagnosis. After receiving a question this year at ATS back in May, we also decided to take a closer look at the molecular patterns of our cohort's cancers. We didn't end up finding a significant difference in genomic alterations between those with a family history of lung cancer and those without, but just wanted to include this for completion. So, in conclusion, overall, we found that lung cancer diagnosis is significantly associated with positive family history, even after adjusting for other lung cancer risk factors among this already high-risk group. And furthermore, degree of relatedness of the relatives, but not the number of family members affected, was associated with this outcome. Some limitations of our study include the self-reported nature of family history. It's prone to recall bias, but it might be more accurate than relying on the EMR data alone. And secondly, there may have been misdiagnoses of lung cancer that were not documented in our system's EMR. For example, if they were diagnosed within another health system, which we don't have access to the records from. And family history should continue to be included in lung cancer risk models. And among screening eligible individuals, this important risk factor should be considered when discussing the benefits and harms of screening with your patients. Screening uptake by targeting outreach to get the most at-risk people into screening earlier. And before I finish, I just want to thank the whole team behind the Jefferson Lung Cancer Screening Program, everyone who helped make this possible, especially our research analyst, Christine Schusted, our lung cancer screening clinical team who works with all of our patients, and a special thanks to Dr. Barta as well, who leads the program. And I'm happy to take any questions.
Great job, Julia, and great work sharing this study as a med student too, no less. That's very, very impressive. Um, I did have a couple questions about your methods. I think you did mention that on one of your slides earlier that you guys included folks that had initially gotten screened for lung cancer up until as recently as July 2024, but only had outcome data available up to October 2024. And since your primary analysis was a count, measure, right? And you're looking at proportions, and it was not a time to event analysis. Variable follow-up between the two different exposure groups, in your case, family history of lung cancer versus not having family history of lung cancer, could potentially have been different. And I'm wondering, did you Do you have that data as far as like the median or average amount of follow-up time for each of the groups?
Yeah, that's a really good question. Our data analyst keeps amazing records of all of our participants, so I'm not 100% certain, but I'm fairly sure we have that data. We haven't looked at it yet, but that's a really good thing to bring up.
Yeah, that's great. Yeah. So as you're kind of refining your analyses, there's a couple different approaches to this, epidemiologic study issue, right? So one is you can do a time to event analysis. Another is you can, report out the data in terms of person time, right? So you can account for in a retrospective cohort study, you can account for the amount of follow-up per individual because you have that data, and then report the data that way, as opposed to just proportions and count data. And then the other thing you could do, which some folks have advocated more strongly than others, is to just cut off the follow-up time so that it's the same across all individuals. And then that's the only way you can sort of completely eliminate the component of time, because otherwise you're going to have to account for time in the outcome analysis in some way.
Thank you for
Yeah, of
that.
course. Tejas, did you have a question?
Yeah, I guess, I know this is obviously, this data from your center, but do you think that there is at least enough impetus to now push this notion forward that maybe including family history as a part of, lung cancer screening guidelines?
Yeah, that's a good question and something I was thinking about throughout this project as well. I don't think we have enough data to say one way or the other whether the official guidelines could be changed, but kind of how I emphasized in my presentation, I'm taking it as a way that we can change our clinical practice and the way that we um, target outreach to certain patients, focusing on follow-up and getting into screening for people who are more high risk rather than changing the actual guidelines right now, because I don't know how possible that would be.
True.
Yeah, I think that's a critical point, Julie, and I really like how you kind of integrated your findings into the literature there. You mentioned, I think, in your introduction slide, the recent publication by Alex Potter and colleagues, and it was a very interesting paper, it actually prompted me to go back and look at it again a little bit more carefully. And in that paper, they actually use the PLCO M212 model, the one that you had referenced, that does, of course, famously integrate family history into the model, which is different than some of the other ones. But within their analysis, they actually found that the vast majority of individuals who had lung cancer, remember that study actually included all people with lung cancer diagnoses already. But they actually found that the vast majority of the people that did not meet USPSTF criteria would also not have met criteria even using the PLCO model among people without a smoking history, right? So one of the critical things that I think big questions that are still out there, right, is what is the actual interaction between smoking status in general, and you can get much more detailed on that if you'd like, and family history. And so one of the, as you already correctly pointed out, one of the limitations of the cohort that you are looking at for this particular study is that it was limited to folks who did meet the USPSTF criteria, right? So they all did have a smoking history by definition. They all had to be they were all considered high risk based on their smoking history. And so one thing that can potentially come up when you're trying to make broader sort of generalizations with regard to family history and sort of cancer risk in the general population, meaning not just limited to people within the USPSTF eligibility criteria, is something called collider stratification bias, right? So that's where you're limiting your focus of your study to a very specific group, right? And so unfortunately, you cannot make any kind of generalizations to folks who would not have been deemed high risk, especially in light of Alex Potter's study that you mentioned. But this is a really nice addition to the literature, and I think it's going to be interesting to see how looking at family history in isolation is going to impact things. And actually, just at the World Lung Conference, I think it was last week, Dr. Allison Chang out of Harvard just announced the Legacy trial, right? Where they're actually going to be doing just that. They're going to be looking at screening folks with a family history of lung cancer as the inclusion criteria and doing free lung cancer screening. So I think it's going to be really interesting to see how your study fits into the grander picture in the context of all these other great studies going on.
Also interesting, in one of the tables that you presented, folks that had a family history of lung cancer, actually, there was a higher incidence of stage 4 disease. You would always think that people that have a family history of cancer and are getting screening, we probably would catch them earlier and not later. But I found that also very sort of shocking. And also, is there a different sort of tumor biology of folks that have family history? Is it more of an aggressive kind of a cancer as compared to not? I don't know if there's data to support that, but quite interesting.
Yeah, definitely.
Excellent. Excellent talk.
Thank you.
Great job again, Julia. Okay, we're going to move on to our next speaker, who is Dr. Kaele Leonard, a freshly minted assistant professor of medicine at Vanderbilt University. And the title of her talk is, "Are pulmonologists better than validated prediction models for pulmonary nodules referred for biopsy? A secondary analysis of the Reliant randomized clinical trial." And take it away, Kaele.
Thank you so much for having me. I'm super excited to present my work that I was working on during my fellowship, which I just finished at Vanderbilt, and I've stayed on as faculty. And so all right, I have no conflicts of interest to declare. So the annual incidence of lung nodules was previously estimated to be about 1.6 million, which is likely higher now due to the increase in CTs for lung cancer screening or other indications such as emergency room visits or other things. And there's been a reported prevalence rate of nodules of about 30% on CT scans. So this is likely a very high number of nodules that are being identified. So it's crucial to identify which of those nodules represent possible lung cancers so that we can diagnose them early. Guidelines recommend assessing the pretest probability of malignancy for indeterminate pulmonary nodules. Prior studies suggested expert clinician intuition outperforms validated clinical prediction models, and that these models may not be as useful in cohorts of patients referred for biopsy. However, the accuracy of physician gestalt and intuition in nodules referred for biopsy has not been previously assessed. So our hypothesis was, in this secondary analysis of the Reliant trial, we hypothesized that physician gestalt outperforms validated clinical prediction models in a challenging cohort of nodules with a high prevalence of malignancy. So a little bit about the Reliant trial. So that's the robotic versus electromagnetic bronchoscopy for pulmonary lesion assessment trial, which was a randomized controlled trial comparing 2 navigational bronchoscopy platforms at a single tertiary care center. Bronchoscopist pretest probability of malignancy was obtained prior to each bronchoscopy. And then calculated pretest was also done using Brock, Mayo Clinic, and Herder models when the PET CT was available. Malignancy was determined by the initial bronchoscopy pathology, and biopsies that were not diagnostic of malignancy were followed for 6 to 12 months to assess for subsequent diagnosis of malignancy. We have now completed the 12-month follow-up for all of these biopsies, although I don't have the most updated data to incorporate here. So that's why it incorporates a range from 6 to 12 months. And then physician gestalt and prediction model performance was assessed based on using area under the receiver operating curves, sensitivity, specificity, and Breyer scores. And then DeLong's test was used for comparison as well. So the results. We had 411 patients who underwent navigational bronchoscopy. It was about split 50-50 male and female patients, with 21% who are current and 47% who are former smokers. In addition, 23% of the patients had active malignancy and 35% had prior malignancy. So this is a very high risk cohort of patients. We also had a median lesion size of about 19 millimeters. The overall prevalence of malignancy in our cohort was 66%. Physician Gestalt and Mayo Clinic models were available for all the patients. Brock was for 318 and Herder for 102 when we had PET CT available, as this is not always something that is done prior to bronchoscopy in our patient population. The average prediction calculations were Brock was at 26%, Mayo Clinic was at 57%, Herder was 71%, and Physician Gestalt average was 64%, which was very similar to our overall prevalence of malignancy. Here you can see the ROC curves for pretest probability with the area under the curve listed on the table, where Physician Gestalt had the highest area under the curve at 0.84, and the other Brock, Mayo, and Herder were ranging from 0.54 to 0.59. And the Breyer scores were also calculated, where Physician Gestalt had the lowest Breyer score at 0.15, with the Brock, Mayo, and Herder higher than that at 0.41, 0.29, and 0.26. Then DeLong's test was used to compare the area under the curve for the different models against Physician Gestalt. And it was statistically significant in all three that Physician Gestalt had outperformed the three clinical models. So in this cohort of patients referred for lung nodule biopsy, physician assessment was shown to be more useful than the clinical models, and that validated clinical models had similarly low predictive ability in this particular patient population, and Breyer score for each model was also higher than Physician Gestalt. Current guidelines recommend lung biopsy for intermediate pretest probability of nodules, leading to an estimated 300,000 biopsies annually, with 30 to 40% being benign. So reclassification of these nodules as low or high probability would decrease the rate of unnecessary biopsies, thus reducing morbidity, mortality, and healthcare costs. Some strengths of this study is that we had a very large sample size from a randomized controlled trial, and we had a prospective and comprehensive collection of this pretest probability. Some limitations are that we are at this was done at a single center with experienced expert bronchoscopists, so that may limit generalizability. As well, we practice in a region with a very high rate of endemic fungal disease, and so that really affects the way that we interpret and assess these lung nodules. So in conclusion, in a cohort of lung nodules referred for biopsy, expert physician Gestalt of pretest probability of malignancy outperformed validated clinical prediction models, and that novel models and biomarkers need to be developed for this challenging cohort of patients. Here are my references. And I want to give a big thank you to the ATS for welcoming me and inviting me for this. And then my whole Vanderbilt Interventional Pulmonary Research team, most notably my mentor and the director of the group, Fabian Maldonado, as well as Rafa Payas, who led the Reliant trial. And I will stop sharing.
Great job, Kaele. Just as good as I remember it when you gave it back in May.
Thank you.
Nice talk. I think this question also came up during your session in May, but just for the sake of our audience here that's live, I'll ask a similar study or a similar question. So, as you pointed out correctly, one of the critical pieces of information, characteristics, let's say, of this study cohort that you're using was that, this was a cohort of patients where the decision was already made to, perform a biopsy. And so, of course, as you stated, the cancer prevalence was around, what I think you said, 66%. And so, as you know, risk prediction model performance is highly dependent on how closely the intended use population in which you're actually using the model matches the validation cohort from which it was initially derived. And so, just I guess to say it out loud, the cancer prevalences of the derivation and validation cohorts for the Mayo Clinic Brock and Herder models were 23%, 5.5%, and 57% respectively. And of course, famously, the Herder model was only validated in 106 patients initially. And so I guess I'm just wondering why you chose those specific three models to compare clinician gestalt against instead of others that were developed in higher risk populations, such as the Gurney model, which had a 67% prevalence, or the famous Vanderbilt treat model developed by Dr. Eric Grogan and colleagues with a 72% prevalence of cancer.
Those are great questions. I cannot speak to the Gurney model because I am not as familiar with that one and the decision that was made to include or to not include it. As far as the treat model, the treat model is looking at a surgical patient population, and so it's a smaller subset, whereas a lot of these patients that we're biopsying are not surgical candidates. And there is a different study that's validating the treat model on this patient population. And so that is why we chose not to include it in this particular study. I think that one of the benefit of the treat model is that the 2.0 assesses for change over time, which I think is an important aspect that comes into our clinical assessment and gestalt for the nodules. But again, I think those were the reasons for my understanding of not including it.
Both very reasonable and practical reasons. The other thing I'll say before I turn it over to Tejas is very similar to the previous study that we just heard about. Another thing to consider is the possibility of collateral stratification bias, right? So again, coming back to the intended use population, theoretically, right, if the world was a perfect place, the intention to use these risk stratification models should be at the stage of when you're still trying to figure out as a clinician what the actual risk is before you made a decision. And of course, in this population, like we just mentioned, a decision was already made, and we're kind of retrospectively going back and theoretically using it. And so theoretically, this could also be, a situation where, because you're selecting out these patients that were already deemed to be high risk by an expert interventional pulmonary group, as you mentioned, the performance of these models may not necessarily be generalizable. And the clinician gestalt, by the way, as well, cannot necessarily be generalizable to a broader indeterminate pulmonary nodule population in which a decision has not yet been made, right? And by whom as well. So just another thing to keep in mind when you're thinking about this data. But Tejas, sorry, I interrupted you.
No, of course, that is an excellent point. Go ahead.
Oh, no, I was going to say the same thing. So essentially, and who sees the nodule, I think also makes some difference. And clearly there, it were people that basically see lung nodules for a living and essentially have seen it for over multiple years. And I think that's one of the big reasons why Gestalt here obviously outperforms the models. Now, I guess, do you see there being a utility in models at all, given that, this and even the previous paper by, Dr. Tanner and Silvestri, they sort of said that, physician gestalts is likely better than any of the models there are?
I think that is a great question. I think there is utility for models. And I think, as Dr. Kim pointed out, I think figuring out what patient population and where in the evaluation of the nodule that the model should be used. And I think figuring out which model for what patient population, what stage is really important. And so I think the reason we did this study as it was easy to incorporate into the Reliant trial that we were already doing. But I think it would be interesting to do a similar thing, but look at our specific patients who were in our lung nodule clinic before that decision of whether or not to go to biopsy or not. And I think that, there's a lot of different models and biomarkers that are also being developed that I think can be helpful in delineating sort of decision making in this particular patient population. So I think there is a role, I think, for each model. It just depends on the patient population in the specific scenario. And I think Dr. Silvestri has a comment.
Why? Because I turned my camera on? Nice job. Hey, listen, look, it's all about the prevalence of cancer. I think the Herder model was really validated. I do think there's a role for risk calculators, and I think it's going to become easier to use them as we incorporate AI into this. And so, what I think we're going to end up seeing is a few key pieces of information put into an AI algorithm that incorporates radiomics plus or minus a blood-based biomarker. But and I agree with everyone who said this. Like, look, I don't need a calculator, right? Because I do this every day, right? But people who are general pulmonologists seeing 5 COPDs and 10 asthmas and this in one nodule, like I think it is useful for them. And I play this game in my clinic with the fellows where I'll say it off the top of my head and then we'll go do the calculator. It is really important to use the calculator in the right population, right? So if you're using the screening calculator, the Brock is better than Swenson model. If you're in a high risk group, I actually think the treat model would work great in the group that you're studying, and I think that's what you'll find when you validate the treat in the IP clinic, which I know a little bit about. So I do think that there's still a use for models, but I think they're going to advance. I think, so for example, people are looking at models that might just suck things right out of the medical record and give you a risk stratification so that you don't have to do anything. You throw your patient in there and it pulls it out, pulls everything out of the medical record and gives you a risk. I love the models. I just think they have to use properly. They're not going to go away. I mean, Tejas can't use one because he can hardly read. So that's a problem for him. He was in my clinic, so he couldn't predict anything. Anyway, let's get on to the next one. I think I came on here I've been fascinated about all these. By the way, the 4th-year medical student, bravo presentation. Tonia, I didn't understand yours, but I loved it anyway. I don't want to take up any more time.
Thanks for those comments, Dr. Silvestri. Always informative. Okay. Last but not least, Tejas, I think you'll do the honors of introducing our last speaker.
Last but not least, we have Andie O'Loughlin, who's a 3rd-year pulmonary and critical care fellow here at the Medical University of South Carolina, who will be presenting her talk. Andie, take it away.
All right, you can see my slides?
Yep, looks
Yes.
great.
Great. All right, thanks for having me. The title of our project was a quality assessment of low-dose computed tomography lung cancer screening at the Veterans Health Administration. So since the National Lung Screening Trial, we have known that annual lung cancer screening via low-dose CT reduces mortality in high-risk patients. The potential harms of screening can be mitigated by maintaining high-quality screening, and that includes both technical factors of image acquisition and structured radiology reporting. Little is known about the current quality of low-dose CT. As part of the National Lung Screening Trial, a quality assurance program was created where they examined technical factors of those scans. They found an overall low rate of errors, for example, scan length errors in about 4% of scans. The VA demonstration project also performed a small quality assurance initiative. They looked at a total of 63 scans. They looked at both technical and radiology interpretations. They found a much higher rate of errors. For example, almost 48% of scans had issues with image quality. There's also been one study looking at quality improvement, and they have found success in improving the use of structured reporting and lung RADS reporting. So our objective was to assess the current technical and interpretation quality of low-dose CT at the VA, and then to evaluate the improvement following a quality improvement intervention. 59 VA lung precision oncology program sites submitted low-dose CT images and reports from the past 6 months. So a total of 2,832 scans were collected in the pre and post-intervention periods combined. Those scans were analyzed by the National Teleradiology Program radiologists. They looked at things like technical metrics, so axial and mediastinal windows, coronal and sagittal reformats, including MIPS, the correct slice thickness, and the correct radiation dose. And they looked at professional metrics, so using a standardized template, identifying, characterizing, and measuring index nodules, including the correct lung RADS designation, and then including the S code for significant incidental findings. When the National Teleradiology Program radiologists found an area of disagreement, a third radiologist adjudicated. Each site then received individual feedback on technical and professional metrics. And radiologists at those sites had access to a self-administered case series, which highlighted lung RADS coding. In the post-intervention period, we collected scans in the same manner. We analyzed improvement based on paired one-sided Wilcoxon-Sign rank tests. And then finally, we created mixed effect logistic regression models to test the effects of additional chest radiology training. So to get to some results, this table shows our technical metrics in both the pre and post-intervention periods. I want to highlight the lowest areas of adherence to those metrics. So in the pre-intervention period, only 64% of scans on average included MIPS. 73% of scans had the correct radiation dose less than the recommended 3 milligray. Post-intervention, we only saw improvement in one area of technical metrics, and that was including coronal and sagittal reformats. We wanted to look more at the detail of the radiation dose and the MIPS that were included in these scans. So the figure on the left shows the radiation dose in our pre-intervention scans, or sorry, in all scans, if greater than the recommended 3 milligray. And you can see that there's a very broad range going up to as much as 20 milligray. And then MIPS thickness, if different on the right, if different than the recommended 8 millimeters, again, a very broad range, up to 2 centimeters in some cases. This table shows the professional metrics in the pre and post-intervention periods. Again, I'll highlight the lowest areas of adherence. You can see that the use of standardized template was quite low in the pre-intervention period in only 58% of scans. Index nodules were only measured correctly in 58% of scans, and use of the S code for significant incidental findings was particularly low at 29%. Post-intervention, we did show improvement in use of the standardized template and in index nodule measurement. And I'll point out that the use of the S code remained particularly low afterwards. Our multivariate model did show that chest radiologists were 3.32 times more likely to correctly measure an index nodule than those without additional chest radiology training. We also wanted to look more in detail at the lung RAD scores that were assigned. This figure on the x-axis shows the locally assigned lung RAD score, and on the y-axis shows the central National Teleradiology assigned lung RAD score. The dotted line shows the area of agreement in those scores, and the size of each colored balloon shows an increasing number of scans at that area of disagreement. Visually, you can see that there are more balloons and larger balloons below the dotted line, suggesting that locally assigned lung RAD scores tended to be overestimated. And you can see that the highest area of disagreement was at lung RADs 3 versus 2. So in summary, that highest area of overestimation was at lung RADs 3 versus 2, which does correspond to a difference in patient follow-up of 6 months. We did show some improvement with quality improvement in use of a standardized template, and index nodule measurement. But overall, although this QI intervention was low intensity and low cost, it did not improve most technical metrics. Lastly, I'll say that the use of the S code was particularly low, both pre and post intervention, and it's something that we want to look into more. Thank you very much.
Andie, great job. Very interesting work. I feel like this might just be my own knowledge deficiency, but I don't know of too many other studies looking at the technical aspects of actually performing, low-dose CT for lung cancer screening. So I think this is a really unique data set and really unique study that you've presented. I was wondering if you could provide a few more kind of like details regarding the actual interventions. From what you were describing, it sounds like it was a two-pronged approach, one at the site level and then one at the radiologist level. And I was wondering if you could provide a little bit more details for both. I think you had mentioned so far that for the sites, it was they were basically just being told that they were being measured. They were given like the performance metrics so that they knew how they were performing, it sounded like. And I guess I was just wondering like how that was provided. And then for the radiologist, the case series, like what was actually in those case series, and how was it administered as well?
Great questions. So I think this was an imperfect intervention just by the nature of QI, and certainly in a trial would have been designed differently, but as I said, it was low cost and very low intensity. So basically, within the VA leadership, there's, varying levels of people at each site and then within each VISN, so group of sites. And each site was given, the leadership was given via email feedback on that specific site. That was put together by the National Teleradiology leadership. So they looked at that site and said these are the things that they could improve on from a technical perspective and from a professional perspective. And those sites were required to respond to the technical metrics, saying that they had addressed those. In terms of the professional metrics and the radiologist level, that was basically, again, put together by National Teleradiology leadership, looking at overall trends and things that they had seen from the pre-intervention cases. They found examples and said, here are some changes that have happened in lung rads recently. Here are some things that that were common mistakes, and radiologists had access to those on the site level. They were not emailed to individual radiologists because we don't know which radiologists read each study. They were emailed to the site and VISN leadership, and radiologists did not have to confirm that they had accessed those. So definitely a limitation there and a limitation of quality improvement. But in a perfect world, we would know that each person had reviewed those things, and that would impact the post-intervention data.
And then just quick follow-up question. I think one of the key findings was that figure you showed at the end, as far as like sort of like, you showed that matrix of discrepancy between the expert radiology national panel and the individual radiologist. Do you have the individual level data to be able to say sort of why that was? Was it just a difference in measurement? Like, as you suggested, that chest radiologists were much more likely to, correctly, or at least in more in alignment with the expert adjudicators, measure the nodule size as opposed to the non-chest radiologist? Or do you know why that might be that there was that discrepancy?
That's a good question. I think measurement was a common reason for discrepancy, especially looking at like 2 versus 3. I think measurement is a common area of discrepancy. Thinking about other trends, I remember seeing like different lung rads 4 designations, and lung rads like 0, those kind of things being different was another trend. So I think measurement definitely impacted it, and that is sort of difficult to, I think, convey in an intervention, how to correctly measure. And so something that I think could be targeted for improvement at different sites.
And it looks like I think Gerard has his hand up.
Yeah, great job, Andy. I would say I want to ask a question, but first a comment, which is, we screen at 7 hospitals in South Carolina and have every Monday screening tumor board where at least 10% of the time we're correcting the lung RAD score, and that's a pulmonologist correcting on behalf of, and it goes in both directions. They're uprated, downgraded, most of the time actually downgraded from a lung RADS 4 to 3 or 3 to 2. So I think there's a lot of variation. But the question I have for you, I'll start with the comment, which is I've heard this number now on a number of occasions from people like Ella Kazaruni, who's a radiologist at Michigan, that there are only about 800 slots for dedicated chest radiologists. And so if you were the czar of healthcare, what would you do? Because there's, lung cancer screening is increasing. We have to get these things done well. And by the way, for a low-cost intervention, the fact that you moved by 20 points using a template, that alone is going to be a massive help to those sites. But what do you do? I mean, community docs, they're reading, a mammography one morning and a bunch of ankle films and a hip film and then, 10 CTs for lung cancer screening. What do you do? We can't,
Yeah.
we're not going to have enough chest radiologists. How do you fix it?
I think one thing that comes to mind is the reimbursement for low-dose CT is very poor. And so I think if people don't have incentive to read it, then they're not going to want to do a lot of those scans. And so I think figuring out the importance and showing data that we have improvement in patient outcomes, also important to motivate people to want to be trained in chest radiology.
And how about a training module for them?
Yeah, absolutely. I think we didn't show improvement in a lot of things, but like you said, very low touch, we were able to improve a couple things. And so if we could refine that intervention and have it be like VA wide, something, everyone has to do tons of training when they work at the VA and those TMS modules come up, and something like that would be not particularly fun, but could be very informative and actually change people's practice. So I think that might be something like that would be easy to do.
I think the other trend's going to be secondary AI readers. I mean, they're available, and at least to point out the highly suspicious findings on a screening CT. I think that's going to become more prevalent because I don't see any other way. I really don't. We're seeing what community radiologists do in our outlying smaller hospitals, and so it's really not good. Great job.
Thank you.
All right, at this point, I'm going to open it up to anybody asking questions about any of the different talks, since we still have all of our 4 presenters here. I see that a few more folks have come off camera, so feel free to just come on mute and ask any questions. But I guess I'll ask one in the meantime, though. So just going off of that discussion, Andie, I was wondering if you were aware of, or maybe you're planning, you're leading yourself, what the future directions are at the VA. Like, are there any plans for targeting sustainability of the QI interventions that you just reviewed, or intervention revision, or any kind of modification? Or so what is the plan going to be across the VISNs at the VA to try to improve what we just talked about?
That's a good question. I don't know about sort of next steps in terms of refining the intervention. But I know one of the things we're looking at more is the S findings, and trying to get a better understanding of what's going on with that particularly low number, both from a primary care perspective and a radiologist perspective, and sort of what people think about the use of the S code and how people might want to use the S code. So that's sort of a next step.
Yeah, I think that's huge. In our in our official ATS research statement, that came up obviously a lot as far as just the sentiment that people at their individual sites were saying that it was being used highly variably. So it's not just the
Mhm.
VA, I guess, is my point there. Lots of different
Absolutely.
thoughts in that paper about what we can do about that and what different study questions might look like. And it looks like Alex just put his question in the chat, and I'll read it for everybody. And for Andie again, did the local radiologists and the expert reviewers use the same version of lung rads? And then also the number of years of low-dose CTs that you were looking at across the whole study.
That's a good question. I don't know that there was any sort of instruction or data collection around what LungRad's versions people were referencing, but the data pre-intervention were from 2023 and post-intervention were from 2024.
Gotcha. Um, Wonderful. Any other questions from anyone on the call here? Well, I'd just like to thank all four of our presenters today. You guys all did a wonderful job presenting your very interesting and diverse spread of research topics. This again, like I mentioned, will be recorded and will be uploaded, so it'll live forever. So folks can come back and listen to these amazing presentations once again. And we really heard the full breadth, right? I mean, we heard about use of novel immunotherapies that aren't even on being used clinically yet, and ones that, nivolumab, which already is, of course, on the market, and how that's infecting the tumor microenvironment, all the way to quality improvement initiatives at the VA for lung cancer screening, to pulmonary nodule risk assessment within now very famous clinical trial, and then a presentation from a medical student about family history, importance of family history in a lung cancer screening population. So kudos to all of you. Great job. You guys truly are rising stars in the field, and I'm really looking forward to future studies you guys will be presenting and publishing, I'm sure, in no time. And so that will conclude the webinar. Thanks again, everyone, for joining.